for today's session. First, I'd like to welcome Dr. Jessica Fry, who's an assistant professor at the Northwestern University Feinberg School of Medicine and an attending neonatologist at the Ann and Robert Lurie Children's Hospital of Chicago. Her counterpart, Dr. Carrie Mackett, I'm not sure if that's how you pronounce her name, will be joining us shortly. I'm also thrilled to welcome Suzanne Ryan Jackson, who's a parent volunteer and parent co-lead the Lurie Children's Hospital NICU Family Partnership Council. And today we'll be learning from this really innovative team about how they've optimized family engagement and improved outcomes for their vulnerable infants and families. As always, please feel free to chat in any questions. Otherwise, I will plan to facilitate a Q&A after their presentation. Thank you so much again to our speakers for joining us.
Thank you so much for having us. We are delighted to be here and share a bit about our progress from inspiration to local work. So I'm going to go ahead and share my screen with our slides. And again, Dr. Mackett will be joining us as soon as she can. I do anticipate, I think I might have shared the wrong slide there. It'll take just a moment. There we go. And I will begin from the beginning. So the title of our talk today is Better Together, Partnering with Families to Improve NICU Care. And we are so excited to be able to share both our local work with you, and selfishly, we're excited to hear about some of the really incredible things that we know your team is doing as well. Just a brief outline for our time today. Suzanne will kick us off, importantly sharing her family story, which really is the inspirational why for so much of the work that we do. We'll describe building family support locally within our NICU and some experiences there. Our experience growing in systematic partnership, both locally and some references to what's happening both nationally and internationally. And then we'll share a little bit of our personal Lurie NICU Family Partnership Council experience. And we hope to have time for questions as well.
Absolutely. So thank you everyone so much for letting us share the work that we've been doing with Lurie here today. I am Suzanne Ryan Jackson. I am a mother to an almost 5-year-old. She will be 5 at the end of this month, Addison, who was born at 25 weeks and 1 day back in 2019. I had been hospitalized with severe early onset preeclampsia, held on for about 15 days, and then delivered my darling 1 pound, 4 ounce miracle child. As you can see, she really has blossomed into a wonderful girl. Of course, we have our challenges, but you know, it really has been quite the journey. And she did spend 173 days, so just short of 6 months, in the NICU between the hospital she was born at and then at Lurie we had transferred to for some cardiac specialties that the level 3 NICU we were at couldn't handle. And through this experience, you know, on paper, I really am that ideal NICU parent. If you were to define somebody who had the measures for success to have a you know, enjoyable experience in the NICU, I work full time. I've spent 16 years in healthcare consulting. So while I'm not a medical professional, I understand the ins and outs of the medical system. I've spent time doing process improvement for large hospitals, looking at revenue cycle, looking at patient experience, looking at patient registration. So I certainly understand, you know, what goes into a prolonged hospital stay. I'm married with a partner who is also successful. My job gave me 6 months of fully paid maternity leave, as well as flexibility to work remotely so that I was able to work from the NICU and save some of that leave for when Addison was discharged. I have a support system. I have family. My parents are close. You know, I literally on paper have everything. We have sufficient resources. I didn't have to worry about how I was going to pay for parking at the hospital, how I was going to, you know, eat when I'm at the hospital instead of at home. Like, I literally was the definition candidate to have an okay outcome. And when I look back, I can honestly tell you that that was by far the loneliest, the hardest time of my life. And if it was hard for me, I can tell you that for people who are not as privileged as I am, who don't have the understanding of explanation of benefits and what my insurance is going to cover, it is that much more isolating for them. So through this, I really wish that somebody could have told me, now looking back almost 5 years later, you have the chance that it's all going to be okay. And through this experience, I kind of set out to say, hey, if I can make this better for one person, let's make that happen. And it just so happened that through our stay at Lurie, I had the chance to meet Carrie while she was doing some research, and wanted to pick my brain. And it really was a match made in heaven, since I had spent time doing patient experience consulting for so many years. But I think the moral of the story is, it's not just about the patient, it really is about the family. And the family's experience and journey really can yield better outcomes for that child. And so we're excited to share with what we've done here, and recognizing that the families really are a key component of that care team.
Thank you so much, Suzanne. So we'll begin talking about our shared work by talking about our approach to building family support within our local NICU. And as we do that, we'll first describe to you just a brief overview of what our unit looks like. At Lurie Children's, we have a 64-bed mixed acuity unit with private rooms. We have approximately 500 admissions per year, and 12 to 25% of those come from our emergency room. About 35 to 40 come from the delivery hospital, which is right next door. Lurie Children's is kind of this building over to the right of the picture. The delivery room hospital is right next door, just separated by a bridge. But also variety, such as from where Suzanne and Addie came from, of local outside hospitals that refer to us for a variety of reasons as a level 4 surgical NICU. The average length of stay at within our unit is 54 days, so a fairly long length of stay. And we recognize that we take care of babies all the way from right away at 24 weeks gestation to babies who have been with us for up to and sometimes over a year of age. 31% were admitted for surgical interventions, and 23% were admitted for respiratory diagnoses. So though absolutely every NICU admission is a life-changing event for a family, we see a lot of families who come to us with a lot of unexpected reasons and stay for quite some time. We know that supporting those families is crucial. We'll begin with just a little bit of terminology, because what we're going to describe today goes by various names. So we think about this as promoting patient and family-centered care, but other terms that are used and really that are part of this work are family support, family engagement. And here we just share the definition that came from the Institute for Patient and Family-Centered Care, which describes patient and family-centered care as working with patients and families rather than just to or for them. The IPFCC goes on to describe their core concepts, which include respect and dignity, information sharing, participation, and collaboration. So really what we're talking about is patient and family-centered care, and really goes beyond that to trying to promote patient and family-centered care through patient and family partnership. These are important concepts. These are things that all of us working within the NICU space, for having the power of hearing words like Suzanne's, really know that these are valuable, important concepts that we need to actualize. But it is hard to move from concept to practice. And in general, across neonatology, there has been a lack of awareness about strong evidence for incorporating family partnership within the NICU setting. We recognize that hospital systems generally have been designed for the efficiency of healthcare workers. So the way we do things is the way we do things to make our lives easier. There could very well be better ways to better incorporate the perspectives of families. And when you look at the literature on practices that promote family-centered care and family engagement, most published studies utilize really comprehensive programs so that they can control variables and impact outcomes. But just seeing a study like that, where so many variables are controlled for, can seem overwhelming for individual units to think about planning major programmatic change. And there's a role of negative cognitive biases that make it hard to be that little orange airplane that's deviating from the rest of the pack. So this, in order to kind of make ourselves that orange airplane and to deviate a bit, we began with a study to try to create some buy-in, to try to understand our local experiences and be able to share that with our partners. And with that, I'll turn over the rest of the slide to Carrie Baku, who was able to join us.
Yes, again, sorry you guys about being delayed. I don't know if Jess shared with you everything that's going on at Lurie, but it's a little bit of a atypical environment for us right now. So things have been a little off kilter today. But anyway, thank you so much for having us. We're really excited when Stephanie Burke brought up this opportunity. So thank you again. But yes, as Jess said, we really felt like we were running up against a lot of pushback from even our partners, from nurses, from leadership, and felt that like at least many clinicians respond to research. So we thought we'd start there. And we started with just a pretty simple descriptive study. We were looking for families that we could just capture through convenient sampling. So we just kind of combed the unit. And we're looking for anybody who'd had a baby in the NICU for at least 5 days, just so they could have some experience to reflect on. We gathered some brief demographics, but really then wanted to kind of hear more about their experience after they went home, so they could have a little bit of time to kind of reflect on that. We offered them either a choice for a phone interview or an online survey, and it was fairly mixed between the two, kind of how in terms of the number of ways that we were able to capture the data. And then we also did a chart review to capture clinical data to see if there were any correlations between, short and long stay infants and different things like that.
We're grateful for Suzanne's partnership in developing the survey and phone interview questions. We definitely benefited from her refinements.
And one thing I will say also, which we did not plan on, is I think we got the IRB approval for this in like February 2020, was it? So it was, right as we were planning this, it was the start of COVID. And that definitely, I think, changed a bit of our data collection in terms of both the capture and the sampling, but certainly the family's experience for everything that they had to go through, obviously. So just to kind of summarize, just in the time that we have here, really the big takeaways we did a qualitative analysis of the results, was that family support meant different things to different people. That's really kind of no surprise. Some families, really described family support in terms of the material things. So like the parking passes, because our parking downtown Chicago is expensive, breastfeeding coupons to get meals in the cafeteria, and other families meant more emotional support. So if they developed a connection with our social work team or different things as being support. They definitely spent a lot of time describing the ways that COVID changed their experience. I'm sure all of you in your various roles have reflected on this and witnessed this kind of throughout your experiences over the last few years. They identified many opportunities that we were able to really use to kind of build a framework to make change for things in the coming years. They particularly talked about developing connections with other NICU families as being really important. They described this in a couple of different ways. Some was the traditional, like meeting someone in the break room that we have for families and developing, almost a friendship in that setting. Sometimes they described connecting with other NICU families online through social media channels, maybe somebody who'd gone through a similar experience with them or a child who had a similar diagnosis. Sometimes it was even knowing someone who had a cousin that had delivered a baby prematurely or something, to some example like that. And that person had maybe facilitated a connection, and they would maybe connect over phone or email, things like that for support. And then this was somewhat of our secret agenda. Maybe it wasn't secret, but we wanted to get parents' impression about what they thought of building a resource parent program, because we had kind of sensed that these connections with NICU families and people who had actually been in their shoes would maybe provide a lot of benefit. Obviously, clinicians have their best interests at heart, and we always try our best, but we don't really know what it's exactly like to be a NICU parent. At least most of us haven't been in that exact experience, and that nearly all really endorse that idea. Thanks, Jess.
There we go. So these were the types of support that came out from our qualitative analysis that families described. As Carrie mentioned, some families described material assistance, so parking, food coupons, staying at the Ronald McDonald House. Many families emphasize connections made with other NICU parents, whether in person or online. Many families, when asked to just cite sort of what felt supportive throughout their NICU stay, mentioned particularly help from friends and family. And this is challenging, especially given the time frame over which we were surveying, because most of our patients and their families were relatively isolated within the hospital due to restrictive visitor policies at the time. Families also cited communication and education that they received from NICU staff as being not only kind of good information, but also a feeling of support. Many families described important relationships with NICU staff, particularly and not surprisingly bedside nurses. And then families also mentioned particular hospital or NICU-based programs that are really designed to offer family support. So things like local scrapbooking sessions that were put together, or one of our family partners described feeling like she had a glass of wine every time music therapy came in to engage with her son. As Carrie mentioned, the timing of the study was interesting because it really was in the early days of the pandemic. So it was something that we had not planned for when we designed the questions and designed what we intended to ask, but it was something that came out very strongly. I think this is important, and these are just representative quotes on this slide that I won't read through directly, but recognizing that though our restrictive visitor policies have changed, there's many sort of long-lasting effects of the COVID-19 pandemics, kind of small but subtle ways in which both our society at large and our hospital systems have changed. So whether that's changing families' financial situations, whether that's worrying about kind of visitor policies and other families coming, whether that's in the height of a cold and flu season, recognizing that many staff members coming into a room at one time feels overwhelming for families due to the risks of illnesses. You know, these are all considerations to take with us moving forward. From these early results of a study, which again, we've had a not so secret agenda to try to build buy-in for growing systematic partnership, we also recognize that systematic partnership is something that is growing not only locally at Lurie, but across the country. So Carrie, I'll let you go from here.
I will just pivot for just before we get back to kind of what we did with our work, just to again go over a few concepts, and much of this may already be things that you well know, I'm sure, in your practice, for given all the impressive work that you've done that we've learned about through Dr. Burke and some of her partners. But basically, when we think about family engagement, obviously in family-centered care, there's certainly the level of providing that care directly to the patient and family. And obviously that is very important. And there's a lot of different ways to do that. But to really transform and make the care feel comprehensively family-centered care, you really need to engage families at a higher level. And this can be done at an organizational level. And this could be at an institutional level, say at your particular children's hospital or your delivery hospital. This also could be done at an organizational level, such as through a perinatal quality collaborative like you guys have here. I know that, and we'll get into a couple other slides of some examples of that. And then even at the, at a much broader level, but really bringing this into policy. I'm sure many of you are aware of what the AAP level of care statement that came out again in May or June of this past year. And they really emphasize this in kind of their policy statement, if you will, about emphasizing the importance of family-centered care and the way it should be delivered, or at least some examples towards that. Go to the next slide. And this you might have to just kind of click through, I think, Jess, but thank you. I'm sorry, she's delivering the slides from afar. But basically, it thinks about just that, not just a family informing you of their needs and you trying to adjust and provide their needs at the bedside, but really engaging them and both their expertise and specifically lived experience and how to transform change and make improvements at a more systematic level, and really advocating for that. And there's numerous examples actually out there in the literature. And again, many of you are probably engaged in this type of work, but it can happen anywhere in the quality improvement world, which is what you guys are obviously embedded in, but certainly examples out there for that partnership and how it can enhance research, Both of these, I think, can help really think about the next thing there that's talking about outcomes. We spend a lot of time thinking about outcomes, both for QI work and for research studies. And again, we obviously have the things that are measurable. Obviously, it's a big part of, SMART aims and things like that, that things are measurable that we can capture. But we also want to think about how we can make sure that what we are measuring is actually valuable, not only to us as systems or clinicians, but also to families. And so there's also a lot of literature out there. Annie Janvier and Keith Barrington do a lot of this writing in their partners about what clinicians often use as an endpoint or an outcome may be quite different than what a family feels is truly valuable as an outcome, and how can we kind of move that needle so that the things that we're trying to do and trying to improve are really what families think that needs to be improved or think that needs to be studied. There might have been one more. Yeah. Oh, that one last, I'm just going to highlight on that one, if you don't mind going back to that last one. Is just an article I just want to highlight because it's one that if you can only take away one article that you're going to go look up at the end of this talk, I think this is the best one. It is from Annie Janvier's group. Dahan is the first author. I want to say it's 2021, maybe. We could probably drop it in the chat if you can't find it. But this is just a really great framework and structure about how to engage families. So if you're looking to bring them into whatever, scope of practice you are all each in individually or as through your teams, this has a lot of great examples and kind of the framework for how to engage at deeper and deeper levels. Anyway, so that's a good one to highlight.
We'll share a slide that has a graphic from that paper in just a moment as well.
Oh, that's right.
First.
So again, there's a lot of different ways to do this. This is a slide from some work from Bonn, basically talking about the different ways that you can have family advisors engaged. And it can, again, be anything from having, parents actually reviewing different things. So educational materials, right? So again, if we can draft something that talks about how to go home with an NG tube, but if you don't have not that that's not going to be good, but think about the level of detail that a parent might review that with and might be able to find opportunities that the language can be changed or something could be explained in more detail, because obviously as clinicians, we all are in our own experience. And so we, have our bias of what we know. And a lot of times when we develop materials and programs, it's kind of with that lens, but a parent may come to it from a very different lens. There's ways to bring in parents in quality improvement meetings and various things and committees. There's actually support on unit that parents can provide. Parents as faculty is, family as faculty is kind of a word or a phrase that you may hear often. And having families help educate even trainees or nurses on, again, their lived experience, bringing them in as peer support to help other families that are, in your unit currently in various ways, family advisory councils, there are some, and then there's actually events. And so maybe you do, graduation celebrations or reunions or various things, or maybe it's, again, the scrapbooking example or knitting nights and things like that, holiday times. And so there's a lot of way to support these, both with parents in person, but even from afar. Sometimes it can be challenging to get former parents into the NICU. They're obviously very busy taking care of their infants that were just in the NICU, many of whom may have gone home with complex conditions or medical needs, and they just don't have the time to devote to that. As anyone who's got young children, even without health conditions, I'm sure can attest. There's also just the burden of coming into the hospital if they live further away and things like that. But there are ways to engage families in any of these in a remote setting, whether it's through video conferencing type of things, whether it's actually just recording a video of, say, something that we're trying to talk about right now is how can we enhance primary nursing and relationship-based nursing. And we thought about having a family member create a video talking about how important that is to them. And then that could just be shared with nurses on orientation. So that way a parent doesn't have to come into every round of new nurse orientation, but that might be a way to kind of share that message. We also have family members that are working on a newsletter, and that might just be left quarterly or monthly at families' bedsides, but they can kind of provide that parent-to-parent support through a written way too.
So this is the graph that comes from the Dahan paper, which was 2019. I thought it was just a little earlier than 2020. We wanted to spotlight this particular figure too, that to highlight, it says some of the same things that Carrie just shared from the Vermont and Oxford Network slide, but in a little bit of a different way, because we recognize that for families who are coming in and volunteering their times and are really engaged in this work, yes, it is absolutely a passion type of project where you find meaning and purpose. But there are risks and complexities, both on kind of how families might feel with different interactions with other families or different interactions with providers, and reliving some traumatic experiences from their own NICU stay. There's also complexity of just how to make these things go well on a staff side as well. So this is a neat figure that describes a variety of opportunities and brings it from sort of lower risk and complexities where there might be less contact directly with current patients and families and less contact or need to come into the hospital that could be reviewing literatures or evaluating protocols, all to much more intense interactions of direct peer-to-peer support, bereavement support, complex meetings, things like that. And so lots of different opportunities, both for family engagement, but also for the opportunity to care for the carers or support our family partners. Carrie, I think this one was you as well.
And kind of continuing on with examples of how this is done in a variety of settings. Certainly many of our peer institutions, throughout, and I think this slide was originally, we presented this at the Children's Hospital Neonatal Consortium meeting that was actually in Denver in October with Stephanie and some other partners, Emily Foaz, I don't know, and Sahara Cahoon, I don't know. I think Emily, I know, is part of your organization. I don't think she's on the call today, but I know she's been involved with the Define work before. But peer institutions, so like many children's hospitals, at least we are aware of, have structured programs that are starting to engage family advocates and family partners and family advisors. I imagine many delivery hospitals are as well. I just don't know that detail to the same. Oh, they are there. Oh, hello. I see them on the chat. Wonderful. Hello, you guys. You should recognize some of these slides then. So many regional organizations, much like your organization, Illinois also has one. In fact, Illinois' project in, I'm also getting my years wrong. I want to say it was 2021, but maybe I'm continuing to misremember the actual date. But they had one of their quality projects was on family partnership. And so they had kind of a mini series. It wasn't one that was done with like a full PDSA cycle, but it was more kind of an educational toolkit. I believe it is still out there on their website. And if not, I'd probably be happy to chase down those materials if it's not. But they kind of had a lot of materials out there on how to help hospitals and different organizations engage family partners. There are many national organizations that are also doing this. So the NEC Society is really, I think, one organization that has really led the way with this. I really think they're a shining example. Jen Canvasser is a former NICU parent who's one of the founders of this and has just done tremendous work. They've also put out all sorts of educational and guideline type materials about how to run conferences that are all inclusive, that also engage families, and all sorts of principles you should use, using first names so that everybody is on a level playing field, all sorts of details that you may not think of right away, but actually probably make actual difference. Vermont Oxford has done a variety of work in this. Children's Hospital Neonatal Consortium has done this in a few ways. I think we're still growing, and Jess and I are both pretty involved with that organization and continuing to look for ways to develop the parent engagement piece within that organization. There are people that are bringing in parents to speak at conferences. I know I'm part of our AAP District 6 organization here, and we had our conference last September. Jess was one of our speakers on this topic, and she brought in a family partner to speak with her for that. Suzanne has spoken with us not only here, but we gave a similar workshop. It was actually at a social work national meeting, and engaged a family partner there. And we're seeing this happen in other ways too. And that's also a way to kind of deliver impact. I know in planning our AAP conference for next year, we're also going to bring in a parent speaker with a child with a condition, with maybe most of you are probably familiar with the pulmonary vein stenosis, which is a condition that has changed dramatically in the treatment options that are available just in the last few years. And we've seen remarkable improvements in survivorship. And so a couple of our early families that kind of went through some of that. And I think that that will be quite illuminating for the audience to really hear about this condition from a parent's perspective, since it's changed so dramatically. Even U.S. News and World Report, which many of our hospitals, at least those children's hospitals, pay a lot of attention to these rankings. There is a question on there, and you get points if you've got a parent family or patient family. I think they call it an advisory committee officially, but it has to have actually direct impact to leadership and management decisions. So I think they're really recognizing the importance of that. These are some more collaborative models. Again, kind of a pictogram here from VON members and a VON project that they have done in the past and how they're trying to engage families. Another important organization to mention is the Family Centered Care Task Force. This is spearheaded by 2 neonatologists and a family partner, Malathi Balasarandam, who's in California, and Colby Day Richardson, who's in Rochester, New York. As well as Kira Sorellis, if I'm saying her name correctly, who is the founder of the NICU Parent Network. And they have built really this broad family-centered care task force, somewhat under the umbrella of the AAP, but it's not officially an AAP organization. And they really, their main thing is bi-monthly webinars, and anybody can join. It's totally free. So you can go to their website and sign up if you're interested. And they have a variety of speakers, both parents and healthcare professionals on a variety of topics, but all, kind of under the umbrella of trying to improve family-centered care. Lots of things to learn from there. They're almost always wonderful speakers and a lot to learn. They also have kind of a small group format where, and then this year actually moving to a small group office hours format. And so there's just going to be some open times if families, or I'm sorry, if groups or hospitals are trying to engage in this work and have some questions or seeking some resources, that that support is there.
As we were preparing for the CHNC meeting, for which Emily and Zara joined us last year, and we were a little bit curious about just trying to understand where, in addition to what's been published, in addition to what's out there, and in addition to groups that are promoting their work in family-centered care, what our partner institutions are doing. And so we sent a 3-question survey to institutions that participate in the Children's Hospital Neonatal Consortium. So I think on last count, that is 47 different Children's Hospital NICUs across North America, asking them about their center's partnership with families. And what we learned was that about 14% of centers, which were 85% of our survey respondents, so we did not have a completely robust survey response, but those centers, again, 85% of those respondents do engage veteran NICU parents. But that engagement takes multiple forms. It might be something like a family advisory board or a family partnership council. There might be kind of more peer-to-peer support. There might be kind of smaller programs and things. And it really was quite a wide variety. 3 of the centers who responded reported having paid family partnership positions, which is something that I think we'll come back to a little bit later in this talk. And 60% of those who responded reported that they had interest in either developing or augmenting their existing, either developing new partnerships or augmenting their existing partnerships. So this is something that, from what we were able to survey, even with kind of a smaller response rate, is practiced variably around the country. And there are opportunities that abound. So we will turn next to our local Family Partnership Council. Based on all of this information about what was happening locally through the survey that the study that we were able to do, with our knowledge of what's happening around the country, where did we begin and how did we build from there?
And we really, oh, sorry, were you going to do this one?
Go ahead. I think this one was you.
We really wanted to start with the people. Again, kind of knowing the what we were up against a little bit, we felt like we really had to continue that buy-in, and it was most important to get our leadership on board. Fortunately, we got great support from both our division head and our nursing director. They really were both quite supportive in many ways and gave us the green light and lent their kind of sponsorship to the work, which was great. And then we just kind of started setting about making sure we were capturing a pretty broad interdisciplinary group, so that we could have all sorts of different perspectives, knowing that there are many roles that actually are directly providing family-centered care type work as their primary role, especially our psychosocial teams, our social workers, our psychologists, child life specialists, and many of our therapists, case management, and we have care coordinators at Lurie. And so bringing them in as well as nurses, we had some fellows, advanced practice nurses, and then a couple other neonatologists. So we started just bringing people together and kind of explaining what we were hoping to do, getting their opinions and ideas. And really, we had even chaplain services actually. So we really, because somebody brought that up then, is like, oh, we should include them. So it got pretty broad, which was great. And we had a few meetings about monthly to kind of lay out what we thought would be a reasonable structure. And then the next step was to think about, before we built too much, because we wanted to, again, the whole point was to make it parent-centered, and what parents really thought would be valuable throughout an organization like this was to think about the parents that would be ones that could be our partners in this. And we kind of set a few very loose criteria. We basically wanted to make sure that parents were about a year out from discharge. We just didn't want families to be burdened in that first year, knowing how critical is they're finally getting their babies home and wanting to spend that time with them, and not wanting to distract them, knowing they're also very busy with a young infant at home, especially again if there were complex medical needs. And so we really kind of, because we had that lag, then we had to kind of all think like, okay, trying to remember families from a year or two ago, who might be, kind of a good fit. And we wanted to make sure we were also capturing diversity. We have a very diverse unit, and we wanted to make sure that was represented. That, again, you're recruiting for a group of 10 or so, so you're limited by numbers. You can only have so many different types of families represented, but we wanted to at least try to attempt that, both from a demographic standpoint, trying to include parents other than just moms, trying to include different racial and ethnic backgrounds, trying to include different ages, trying to include married families, but also non-married families. The one demographic that was very challenging for us and continues to be hard is non-English speaking or non-primary English speaking families. Because we set this up, and we'll talk about logistics more in a moment, as a Zoom meeting. Again, this was done during COVID, but even still, it's our families, might live far. And so that's so far seems to be the best way for them to be able to participate. That it's just been hard to capture that in a live meeting with 20 people on a call with translator services. So we can talk more about some other workarounds that we've done to try to capture that perspective. And then we also want a different clinical perspective. So some families that have been in the unit for a long time, some families that actually were there shorter because their experiences may be different, but also very valuable and important. Families that may have gone through surgical conditions and needs, and families who maybe didn't, families that went home with equipment, families that didn't. So kind of trying to capture all that. Then whichever staff member kind of identified or maybe had that relationship with the family, which is how they probably remembered them, we just called them. We just looked up their phone number and said, hey, you might not have heard from us for a while, because we don't have any sort of ongoing, and maybe some of your hospitals do, but we don't have any way to continue to connect. I mean, maybe a few nurses have built a relationship and are continuing to communicate, but it's not like we have a email newsletter, or we don't have a reunion or anything. So we just had to call families and see if they were interested. And the response was overwhelmingly of interest. I think, I don't even know if anybody really said no. Everybody was pretty excited about this opportunity. Once families, we kind of talked to them and explained what we were hoping to do, and they were interested. We then did have them kind of go through a volunteer process, which is just like a half an hour with our existing Lurie volunteer services. It's just, again, was online, but just to kind of go through confidentiality, basic etiquette, and things like that. And then we have, since we've had this now for about 3 years, we've had to kind of re-recruit about every year, because it's a lot for families, it's, just like any volunteer thing you do, it takes your time, and you have other things, and your life changes, and you have other things you want to get to. So families have benefited from being kind of released of their experience. Fortunately, Suzanne is like our long stay. I mean, she's in it to win it with us, and we love it.
They're not getting rid of me. I'm here for good.
So it's been really great to have some families that have stayed on the whole time, but other families totally understandably need to take a pause. And then it also brings in fresh ideas and helps us kind of rebalance the recruiting. I will just, in transparency, like, it seemed like a lot of our first group, even though we tried to be very diverse, ended up being less diverse racially than we really wanted to be. And so it kind of gave us an opportunity to reinvest in a broader diversity. And so in for this next group of families, which has been really nice.
And so we began early on. We started with monthly meetings via an online platform. We use Zoom, and we shared a bunch of possible timings, and evening meetings were overall requested by parents, which are still challenging because they conflict with dinner time and commutes and bedtime and things like that. But for the most part, it is easier, I think, to access than others. And we really just wanted to know where our partners would lead us. So we began with introductions, and just in those first couple of meetings with families sharing their stories, our conversations really organically moved towards specific themes related to improvement, that people would describe their experience being recruited for research in a NICU, their experience coming to the NICU, arriving at the Lurie NICU via a transport team, all of a sudden in the middle of the night, unsure about what to expect. So based on those things, we really were able to kind of take those discussions and categorize those into themes that really we could move towards actionable projects. We then worked on building a group consensus and selecting a first focus to try to achieve a first project. And we did, one of our neonatology faculty team members, a couple of our neonatology team members have done some work in QI methodology. And so we wanted to focus on that. And then another key item for our success is parent project leadership. Notably Suzanne as our parent co-lead, really taking on these projects and really making it so that it is parent-led, parent-centered, parent-focused. Now, again, almost 3 years later, we currently have a cohort of 11 active family partners and 16 staff members. Over the years, in addition to our meetings and generating our own projects, we've reviewed greater than 10 guest projects. And those have been, once people were aware that we had a family partnership council, that we were engaging in this shared work together, we had projects such as a new newsletter from our hospital's bronchopulmonary dysplasia team, kind of a pamphlet that was introducing the team, that was brought to our group for family feedback on the language that was shared. We've reviewed various studies, and some of our group have become authors in some of that work. But all sorts of varieties of different guest projects. Some of it is reviewing social media postings that are put on by our Lurie NICU social media team. In addition to kind of more formal review of projects, we want to highlight that we have really enjoyed the support of, in particular, our nursing leadership team, who attends essentially every meeting and often is very quiet, just listening in. But just based on some of the things that were heard, we have seen some changes in our unit. So it used to be that our nursing leadership team, for example, encouraged families to ask bedside nurses if they'd be willing to join them as part of their team, as part of their primary nursing team. We received some pretty important feedback from our family partners in different discussions on trying to provide that sort of medical home within our NICU or continuity of care, that really put families in a difficult situation, that you almost felt like it was sort of a speed dating type event where you're asking nurses and then feeling rejected. And then that just compounds the trauma of already being there and feeling uncertain, both for your baby and for yourself. So that was sort of immediately changed. And there were other items like that along the way. We have seen over the 3 years, as we've shared the perspectives that we've gained from our family partners, as we've shared the projects, and informal, it's hard to measure this, but we've definitely seen a change in our neonatology partners' perceptions of family-centered care. So something that would not have happened at one of our division meetings as we're discussing a new initiative 10 years ago, but now happens on a regular basis, is that one of our partners will ask, what do families think of this new operative handoff project, this new protocol? And so we really do value that the concept of partnership has become more widely accepted across our group. Over these years, we're now up to over 550 volunteer hours, considering all the time of family and staff, which is amazing. And we've been able to hold 2 in-person events for our group, with a third planned along the way. So both kind of a social event for our group to be able to get together, but also really important connections with current families as well. This slide, Carrie, you're muted.
Yeah, thank you. Thought I clicked it. When we started the meetings, and Suzanne, feel free to jump in, we really just started with listening. We wanted to just hear family stories, hear what experiences they wanted to bring up, you know, both just from describing them, but also areas they thought were strengths, areas they thought were weaknesses or could be improved. And we were like, okay, we'll do this for the first meeting and then we'll move on. And of course, it took 3 meetings to hear 10 family stories. And we probably could have listened even longer. So from that, Jess and I did sort of a quasi qualitative analysis to kind of try to group the themes that we took away to help break it into something, you know, a framework that we could really start to build projects from, because there were all sorts of, I mean, so many ideas came forth. We have it on a Google Doc and it is like pages and pages long. And sometimes things come up at meetings again, sometimes things come up at conferences we go to or papers we read or things, ideas we hear. But from this
It
initial,
keeps getting longer.
yeah, it keeps getting longer and very disorganized. But we did, from those first 3 meetings, we took away kind of these big buckets of areas that parents thought. The first one, and the one I think we hear the most about, is really building community. We're a single family room unit. COVID happened to a lot of the families that were in that first group of families that we had. They were all families that had been through the unit during COVID time. So I think this was of particular importance to them. And just feeling very isolated. And, you know, it's hard because even when families are present, they may not even want to leave their room to go do a knitting group or a scrapbook group, right? Because they're there to be with their baby and they're already stressed and worried, and they may not feel like making small talk with somebody, or they may just want to be able to not miss a feeding time with their baby or whatever it is. So recognizing that they want this, but it's also very challenging to be able to provide. Another big with that is the need for mental health support. And again, a lot of this was coming out of COVID, but I think that is only continued, and this is well documented in the literature in many other ways, that not only are you layering on all the postpartum changes that families go through, normally you're now doing this in a very stressful environment, and levels of anxiety, depression, post-traumatic stress disorder are very high, and families really need our support, and they're there in our unit and they don't even really have maybe the bandwidth and time to get the support that they need professionally. And so how can we help make inroads to provide that with them so that they can be better themselves, and then also be more present with their babies, right? Because we're wanting them to obviously take over the care for their babies as they transition home, and be able to provide breast milk if they're there, and various things. So that mental health support really can make a big difference to the baby, not even just the parents themselves. Transition to home was another big thing. I mean, as excited as every family is, and I'm sure you all witness this day to day, it is just a huge transition. I mean, I'm on service right now, and I have a 6-month-old, and I, you know, announced yesterday, I just come on service and the baby's doing wonderfully. And I talked to the mom and I said, I really think, you know, we're going to send him home with XYZ. And I'm thinking next week seems like a reasonable date, you know, kind of expecting her to be excited. And it was the first time I met her, and I just instant panic in her face. And I think, of course, she's so excited. I'm sure she is going to be thrilled to take your baby home, but it is such a big transition for families. And so how can we understand that, and how can we better support them when they make these big leaps? Similarly, also really hearing there's a lot of need for us to improve things when families come in during the orientation. And again, I think this depends a little bit on each family and what their experience is of how they're coming into a NICU versus what type of hospital you're in. So if you're at a delivery hospital or a children's hospital, so sometimes this is a known fetal condition. There has been counseling, but potentially still a lot of anxiety, depending upon the level of complexity about what to expect. And maybe they have heard, okay, there's going to be breast pumps and there's going to be this and there's parking, but then still they have to go through the delivery, and it just, their mind is just, I'm sure, overwhelmed. And similarly, sometimes this is very unexpected, right? A baby is delivered either preterm or full term, but the complications arise that necessitate the NICU care. And so families are coming in from all different types of experiences. And oftentimes what we see, especially at our children's hospitals, is the birth parent is not able to be part of this intake, especially if a baby is coming right from the delivery process. Many times mom is at another hospital, many times going through her own healthcare needs, and it's just a lot. So sometimes babies are coming in the middle of the night, and sometimes they're coming in on a Saturday night, and sometimes they're coming in on a busy Tuesday morning, and it just varies. So how can we streamline that to best provide families with the information that they need to know, knowing that they're already in a state of overwhelm? Research was another area that came up, not as strong, but definitely was an area where families felt like that could be opportune. We're a research institution. We do try to do a lot of research to make major strides in the care of children overall, but especially in our NICU patients. And but there are ways that we could approach families differently, especially in the recruiting and enrollment process. I mean, we would hear stories of a parent giving the baby bath the first time, or maybe just having received bad news about a head ultrasound, and somebody comes to approach them for a research study. Or maybe somebody comes to approach them for 3 research studies in a matter of 2 days, kind of back to back. And that just can be pretty overwhelming for families. So how can we improve that process? Because not only do we not want to stress the parents, but it can have advantages to the research team, right? We want families to be able to participate willingly, and so if we approach them at a better time, then we as researchers may have a better chance of actually getting their participation. And the follow-up experience is another one that families talked about, like not really understanding what the follow-up clinic even meant and the logistics around that. And they have so many appointments to go to, and how to prioritize that. And could there be ways that could be also talked about and streamlined? So transition to home was the one that we let the families, we kind of brought this back to them, and then that was the one they really kind of isolated on.
Yeah, I think with the transition home, we kind of looked at all the different ideas that we had come up with, and said that the one thing that we all have in common is that journey that, luckily, eventually we were all discharged home. And so while there's different, medical things that you're coming home with, everybody has that chance to go home. And so we really took a look at kind of what that lived experience was for each of us, and said, on the Lurie side, there's certainly that checklist of things that have to happen before you can go home, whether it's having your pediatrician set up, taking the right purple crying video, having the right training for whether it's oxygen, trach, G-tube, NG, whatever that may be. But we found that the checklist of things didn't really translate to what happens when you get home, and what happens when you prep to get home. And so we really worked to make this comprehensive guide of the parent perspective, of things that you might not think of as a provider to share with your patients. Things like, hey, you can ask for longer oxygen cording so you're not rolling around this concentrator all over your house. Or you can get certain types of strollers that make it easier to go to and from doctor's appointments if you have a child that's vent dependent. And so we really thought about what are the things that we had to figure out on our own, and how do we share those best practices in the month leading up to discharge, the week leading up to discharge, the day of discharge, and then that first day, couple days, week, and couple weeks home. And really came up with this guide that is now available to access. So as families start to hear about, hey, we're talking about discharge, here's some information that is something you wouldn't think about, but it's meant to be a reference tool to help. We also did a series of resource videos so that we had current parents kind of share their experiences of what it looked like going from the NICU to home, lessons learned. And again, just being able to relate to somebody who has been in your shoes is crucial. It's, great to have social work kind of tell you these things, but unless they've shared that lived experience, it really doesn't impact a parent the way that a commonality does. We came up with a family sharing board where, like I said at the start of this, if somebody had told me that it had the potential to be this good one day, that's all it would have taken to kind of keep me going. And so we've used these parent sharing boards to really kind of share, this is where we started, but here's where we're going. And I think at the end of the day, the goal is to learn from our experiences. And a quick note on the other topic that we recently tackled was kind of that orientation process. When I transferred to Lurie, and I will say one of the other advantages I had, I lived in a 3-unit condo in the city, and our upstairs neighbor, he was a neonatologist who had spent most of his career at Yale and was at Mercy. And I mean, I literally had the resource that I needed. And so he had connected me with cardiology at Lurie, and I had all of that. And I still, transport got there. They said, here's your room assignment. Here's where you park. See you there. And I almost had a heart attack. So again, using that shared experience from the parent perspective, I think it's a 2-page document we pulled together that says, hey, here's where you can park. You're going to get free parking. Here's how you check in. This is the floor you're going to go to. This is the visitor policy. You're going to have a private room. These are the types of breast pumps we have. Things that you don't think are important to somebody in an urgent transfer situation, but simple things that really let the parent focus on what truly matters. And so we're just going to kind of keep going with this, building on that journey home, building on that transfer process. And I think, up next is really how do we build community? But I really do think that the parent perspective, it not just helps better care, but it helps, feel like you're part of that team.
Thank you so much, Suzanne. We'd hoped to be able to add our orientation document to this slide, and then sadly our technical difficulties had driven us our copying and pasting.
I've only gotten 10 emails from Lurie yesterday and today about the technology issues.
We'll get there. So just a couple quick things in closing, because I know our time is running on. Briefly, we want to transparently share some lessons learned, and Carrie already touched upon the first one here, but recruitment is both really important and ongoing. And so it was a goal initially for our family partners to reflect the broad patient population served, and that has been a challenge, just depending on relying on staff memories for recruitments. We tend to remember as staff members families who were with us for a longer period of time, or who we connected with deeply about one reason or another. And that doesn't necessarily lead to as broad of a diverse population as what we would want. And so it's important to keep rethinking, to keep thinking about different ways to identify families who might be interested and able to do this work. We also, as Carrie mentioned, one of the things that we initially had sort of set this out as we would reevaluate what terms look like, but just giving families more of a time limited, we will start out with 1 year and then we will reevaluate from there, I think gives people more of a comfort in knowing what they're joining for. We have used Zoom over the last couple of years, which is a really, just as we're doing today, it's really convenient, but can be really challenging for group discussion. And so we have employed various strategies over the last 3 years, and I think we're getting more adept over time at ensuring that all parent partners really feel comfortable sharing their voices. And sometimes that means a roll call of going through and asking family members who have been quiet if they'd be willing to speak up. We also are grateful that our staff team actually is relatively quiet, just to empower the family voice. Over the last 3 years, we have noted that flexibility and adaptation are key. So just about a year or so now, we engaged in a needs assessment to try to get more of a formal program evaluation. And a lot of that feedback was built into kind of ongoing evolutions of our program. We have lots of goals and lots of next steps in mind in addition to these projects. One of those goals is to really try to compensate people for their time. This is incredible volunteer work, but that it shouldn't have to be volunteer, that part of valuing family perspectives and truly engaging families means kind of paying for that seat at the table too, and enabling families to be able to step aside from their jobs and from other things to be able to do some of this work. So that is part of our project. And another part is building support not only within our NICU, but recognizing that many families have babies that start in our NICU that then go on to be patients throughout our pediatric centers. So one of our partners in our Department of Quality and Safety describes us as flying the plane as we build it, building the hospital-wide support that we need, but those are next steps for us as well. These are just more kind of general challenges along the way, and some of these we already sort of touched upon. And really, I want to focus here just that change, true systematic change, and incorporating parent perspectives requires buy-in for some really important conceptual elements. First, that the belief, and it requires the belief that the well-being of infants and their families are both inextricably linked and biologically co-regulated. This is more than just a nice thing to do. This is incredibly important part of NICU care. It requires belief that optimal care for infants must include care for parents and engagement of parents. And it includes sometimes reimagining current policies, procedures, and roles within the NICU environment, challenging us all to kind of step out of our comfort zone of what we're used to and the way that things have been done, and trying to challenge us all to think about how we can be better. We have been incredibly fortunate to have, again, an ongoing commitment from our leadership and have truly an interdisciplinary approach of team members that have been willing to think outside the box and support each other. But other factors, again, that are important to a launch of a program like this are resources for the initiation of new programs and support to really sustain the model until it becomes broadly accepted. So that's part of building the plane as we fly. Next steps kind of moving forward. And that's all we had planned for today. I'm hoping we might have a minute or two for questions. There's been some incredible work, incredible comments in the chat discussion there.
Fantastic. Thank you, all three of you, for a wonderful presentation. I know that you all have been answering questions as they've been coming through the chat, and I would also direct our audience to the chat. There's a lot of resources that Carrie has shared. We'll make sure that we download this information and distribute it to those who are here today. Let's open it up to questions. Feel free to unmute yourself or chat in a question. I recognize we're a little over time, but I think for those that have remained on, we can hang out for a few more minutes.
Sorry about going over.
Oh, no, that's fine. Well, why don't I get us started? You mentioned compensation. That was a question I had, and I was wondering what approaches you've taken to ensure sustainable funding for those with lived experience to continue to participate in this work.
Well, so far, not anything that is at the level that it needs to be. So it is certainly on our agenda to kind of develop a sort of a grant application for this. Would be obviously the ideal way to do it. Or, I mean, even more ideal would actually be to build it into the NICU budget. This is how some centers, I know like UT Southwestern, I believe, or Cook Children's, there's a few hospitals out there that have, I think it's called Hand to Hold, that have embedded these programs directly into their NICU budget. Or I think March of Dimes, some hospitals kind of have a aligned program with them, and then can also get a parent official role kind of covered through that. We are in the early talks with that with our leadership, but it hasn't happened yet. So in the meantime, we were thinking about bridging with, maybe some sort of foundational grant.
There's a question here from Pia Long, and she asks, have you considered postpartum doulas for support in the NICU?
Not yet, but that is a great idea.
Our NICU happens to be at a point where we are reconsidering family support broadly with the Division of Psychology and Psychiatry as well. So one of the things that we've been able to advocate for based on our work in family engagement is to think about this just a little bit more broadly. So that's another place where we might be able to embed a paid parent position as a family support liaison, working directly with our unit. But I think a postpartum doula would be an interesting angle to consider as well.
Yeah, I think that's really interesting. again, we're primarily focused right now on the children's hospital, which sometimes we have families that are not brought to our hospital till the baby's say 6 months old. But I could see a lot of different ways for a lot of families that support could be really valuable.
Hey, well, we're just 5 minutes over. Thank you again for joining us today. I'm sure there'll be additional questions that come up, and we'll be sure to reach out to all three of you to get some more information. But I really look forward to, your group and our group getting to meet either, in person or even on Zoom to really exchange ideas for how we continue to do this work and in fact do it better.
Yeah, for sure. Thanks so much for having us. We really appreciate the opportunity.
Yes, thank you.
Thank you.
Have a great afternoon, everybody.
Here.
You too.